Okay, so a little bit about me before we start, because you're with me the whole day. So over 30 years in dentistry, I think that's the easiest way to put it. I've been in dentistry way too long to keep remembering how many years it's actually been. 34. 7 years I did in the Royal Naval Dental Branch. Fabulous time in the Royal Navy. Recommend it to anyone. Then I became an area manager with Integrated Dental Holdings, as it was then, and latterly known as now as My Dentist. I looked after 16 practices in London and the South, and did that for a couple of years. Then had my children and did my teaching qualification. So I'm a qualified teacher. Then qualified in health and safety, because I do have a little bit of a crazy love for health and safety. So really for the last sort of 14 years have been teaching CPD nationally and internationally across the dental sector. I do compliance consultancy in practices, so I make sure that all of the compliance is in place, ready for inspections. And 1 day a week, I am CQC registered manager in private practice. And we've got 2 practices in our little sector. So that's a little bit about me. So we're going to start the session with infection prevention and control. I've kind of steered away from disinfection and decontamination just purely because everything that we do is surrounded by infection prevention and control rather than anything else. It's kind of what we do all day, every day, alongside treating patients, of course. So a little disclaimer at the bottom there, consider that the images that I use just for illustration purposes. I'm not selling anything and I'm not promoting anything. Anything that I do sort of go, yeah, that's really good, will be a generic product rather than a commercial product. So just a disclaimer there. So the aims of this session is being up to date with our procedures. So there still hasn't been an update of HTM 0701 for 7.5 years now. April 2013 was the last update. So we've got HTM 0105 for our sort of step-by-step procedures. We've got the code of practice for the control of infections and related guidance, and that gives us sort of like the wider aspects of infection prevention. And we've got the HTM 0701 for waste. We've got L8 for Legionella. So there are various different documents that we have to guide us in various aspects, either of practice management or infection prevention and control. So we are in this session going to comprehend the basic requirements for good decon practice. Look at pre-sterilisation cleaning and the different types of pre-sterilisation cleaning that there is. My favourite slide, of course, goes just before that with the chain of infection. We are going to think about immunisations and talk about those too. The correct use of PPE and RPE, respiratory protective equipment. I'm going to talk very briefly about SOPs and the pandemic, mainly because I think we've done it. We're doing it. It's not like back in the sort of April, May time when I was doing webinars and it was all new and we were all sort of learning together. We're kind of doing it now. I will touch on various aspects and kind of bring things up to date with regards to what's happening out in the big wide world and what other practices are experiencing as well. And then right at the end, we are going to revisit hand hygiene, as we should do ongoing and throughout the year. So hopefully by the end of the presentation, you'll have a better comprehension of the current guidance and documentation for infection prevention and control, the methods that we're using, and really a couple of the theories behind it, where science has actually gone ahead of the documentation that we're using in a couple of instances. So we'll have a look at a little bit behind that as well. So what we're facing then, so within dentistry, there is a real danger of infection from dental procedures. But I will still maintain that we are far more at risk than our patients are. And we'll talk a bit more about that as we go through. Patients, though, do trust us to provide effective infection control. There are things that hit the headlines, and if you've done my sessions in the past at Croydon, then you'll know the sorts of things that I'm talking about with regards to Desmond DeMello and Alan Morrison and the likes of that. And then the GDC in our Silver Standards book says that patients expect to be treated in a clean and safe environment, and that we must treat them in a hygienic and safe environment. Then in England, and I am going to talk about England today, so apologies if you're in one of our other countries of the UK, but I am going to talk about England. We've got the Health and Social Care Act of 2008, which was updated 6 years ago now. And also we've got, which of course the CQC enforce the Health and Social Care Act. We've also got the BDA there that says dental practices have a responsibility to adopt safe systems of working with respect to cross-infection control and decontamination. So, and again, we'll have a look at some of those safe systems of working as we go through. So I don't really want to talk a huge amount about AGPs and dentistry, but what I will say with regards to AGPs is that it doesn't matter how long you've been working in dentistry, we all have or experience, shall I say, what's called micro exposures. And what it means is that in very low numbers, and I'll talk about the chain of infection in a wee while, but what it means is that throughout our working day, we will have micro exposures, which means that each person that presents to us brings their own little set of microorganisms, and we get small amounts of exposure from each of those people and their microorganisms. So what that means is that in low numbers, we are exposed to these microorganisms. They don't cause us any harm, but they also add to our own body's little library, if you like, of infection fighting, the infection fighting library. So those micro exposures really mean that we stay a lot healthier than perhaps some of our other healthcare counterparts. We've always been high risk for pathogens being disease-forming microorganisms. And 5 years ago now, The Independent did a top 50 jobs that were worse for your health. And we came top, yay, go us. We came top in that. And actually, weirdly enough, some of it was for radiation, but that's like minute, but it was for microorganisms as well. And then at the beginning of the pandemic, before we obviously closed our doors, we occupied 4 out of the top 5 occupations for being the riskiest. And still, as it stands, even a couple of months ago, dental nurses were the top for being at risk. The riskiest profession. We knew that though, didn't we? It's nothing really to shout about, but I think it compares the risk for you. You know, dentistry hasn't been directly adversely affected by the pandemic. And actually, I was saying that back in April as well. We're getting more and more contact now, but again, I'll talk about that in a moment. But from an occupational point of view, the PPE that other industries, if you like, were scrabbling for at the beginning of the pandemic, and indeed that we donated a lot of our PPE to, we've been using for decades. We've been using surgical masks, we've been using gloves, we've been using visors. All of these things we take very, very seriously. You know, when you look at the other occupations which very sadly have been adversely affected, like ear, nose and throat and people like that, then, you know, they don't routinely wear what we wear, but do come very close to some very sick and poorly people for the upper respiratory airway. So that's AGPs. Like I say, I'm not going to talk a huge amount about AGPs. New normal. Oh, I swear to God, if I hear that again. But really, it is what we're in, you know. our SOPs and risk assessments. So our standard operating procedures that really, I think probably the one biggest piece of advice I'd give about SOPs is that they are a live document. They should never be written and go, there you go, filed away, those are our SOPs. It really should be, excuse me, it really should be that SOPs are almost written on shifting sands. And even 2 weeks ago, we got yet more documents, and we got yet more updated documents. So we got the, from Public Health in the Infection Prevention Control Toolkit. We got the dental appendix, didn't we, a couple of weeks ago, which brought us yet more joy. And various other sort of prompts to prepare and Chief Dental Officers' missives were updated as well. So we have had a few new documents, well, I won't say new, either new or updated or added to documents other than the HTM. Certainly were sort of promulgated about 2 weeks ago now, 2-3 weeks ago. And with it brought, like I say, yet more reading, yet more, oh, we've got to change this. So there were a couple of things like the move to FFP3 or P3 masks. Once our stocks of FFP2 masks have been used up, we need to have some sort of action plan that says, yes, we're going to use up our FFP2 masks. It'll probably take us, with the stocks that we've got, it might take us 3 months to use up our FFP2 masks, and then we will prepare to move to FFP3 or P3 masks. Start thinking about it now, but I'll talk more about masks as we go through. Fluid resistant surgical masks, so sort of like the level 2 PPE, the one grade up from just our surgical masks. And they tend to have 4 or 5 layers of fabric rather than 3, which the surgical masks are. So it just gives that added bit of protection. Face shields that cover the neck, gowns for AGP chairside. In there as well, you could add the plastic aprons as well. Again, I will talk about it a bit later, but if I forget, I'll cover it now. I'm not over keen on the dental appendix saying that single-use plastic gowns for AGPs. I think it's horrific on the environment. There's a few things that I'm going to talk about on here about the environment as well, and what we're putting into our waste stream. So it does say in there, though, that you can use the reusable gowns and the ones for laundering, which I would absolutely advocate. You know, as our go-to is the reusable, and once you've used those in a day before they're laundered and you've run out, absolutely go to the single-use plastic ones. Plastic aprons are advocated if there is a risk of contamination. So it is also saying that you don't have to use an apron if you're just going to do an exam whereby you're not going to have a risk of contamination. I do sometimes think that some of these things are written and promulgated without actually asking people who are using them, because I'm not sure that there's anyone that's going, yeah, for examinations, yeah, using plastic aprons. So I think there's a degree of common sense, because these are guidance. Okay, these are guidance, they're not law. So they are there to guide you. I've done a risk assessment that says we don't need to use plastic aprons unless there's a risk of contamination. So let's say you're fitting a denture and you're going to be easing the denture. I would say then that you are going to get dust, you are going to get potential, not contamination, but you're going to get mucky. So you could potentially use that. Hygienists, if they're using Profi paste, yeah, I'd use a plastic apron. Or a gown. So I think common sense comes in as well. And that's a dirty word, but yeah, let's use our common sense, shall we? High volume evacuation, air purifiers, UVC and foggers. Not really going to go into those. I think the dental appendix sort of expressed their opinion on those quite clearly. So high volume evacuation, not the suction that we use, that's high volume aspiration. High volume evacuation really will help with the air changes per hour, and maybe sort of get an engineer to guide you, especially if you've got aircon systems or high volume evacuation. Use your engineers to find out how many air changes per hour that will give you. And there is an algorithm on the dental appendix from Public Health England that helps you with your fallow time. So again, I'm not going to really go into fallow time because it's done to death on social media, and the information is out there for you, and that algorithm shows you that default 30 minutes and you can take it down to 10 minutes if you put certain amounts of mitigation in. So have a look at those documents and you can absolutely come to your own decisions on those. Air purifiers and foggers, I think there probably is a place for those. But again, look at the literature, look at the science and see where you go. UVC, I would probably say no. Ultraviolet could be pretty damaging. Get a good tan, but pretty damaging. Training, so making sure that there is a run through of the SOPs, making sure that when we get new documents, is either putting something out to everybody or sitting down and talking about the new documents that come out, just to make sure that everybody's on the same page and they know what they're doing. So the outcome really of reopening in June, or whenever it was that you reopened, or whenever it was you got back to your new normal, then I think everybody has really come to the conclusion that we're having longer appointments, and we're going to have less patients in the building. Wasn't so much of an issue during the summer when the weather was nice and we could have people outside. Not all practices are blessed with a large waiting room or somewhere that you know, we really can sort of house people safely with social distancing and having a minimum amount of people in the practice. So yes, longer appointments so that we can take in the fallow time, that we can clean down between patients, especially if we're floor mopping. I personally don't think that the clean down between patients is any different to if we pre-COVID and we had a filling in, we'd still be wiping everything down, going from clean to the dirty zone. The only thing we wouldn't be doing would be mopping the floor. So again, follow the guidance on all of that as well, and come to a decision as a team. Come to a decision as a team rather than one person saying we will be doing this and we won't be doing that, because everyone should have an input really. I'm not going to mention new normal again. Staff working together. Okay, I do want to cover this. For those of you on social media, whether you are on the management forums, the nurse forums, the dentist forums, at least a few times a day, I am seeing one of our staff is a contact, is having to self-isolate. Do we have to shut the doors? Do we have to deep clean the practice? There's a couple of things I really want to point out on this, in the fact that as a broad sweeping statement, so I don't want you all sort of putting in the chat box, oh no, it's happened here. The self-isolating people and the people within the dental team that have tested positive for COVID, I would say that, I personally will say that I haven't seen any that have contracted it through work. They have known someone who's had it, they've been a contact, and they have subsequently tested positive, or they've been a contact outside of work for someone who has tested positive. So covering a few things, I think there's a couple of ways that you can approach it. Please keep social distance when you're at work. Take it seriously, because otherwise we're going to be back to where we were in April and May, shot, because everyone's having to self-isolate. So you're making sure that you are socially distancing, preferably not having more than one person on reception. I'm hearing now that if you've got one receptionist that tests positive, then the other receptionist is gone as well, because they can't keep the 2 meters and they're perhaps sharing a phone. So do have a look, although that's Public Health England, and it should really get raised to the tiers, through the tier levels, on test and trace. And they should be saying that actually you're wearing PPE, you're not sat facing each other when you're on reception. But somebody's quoted Public Health England as saying that using the telephones has been an issue because you both use the same phones. So I think really take stock and take a look at what you're doing in the practice. Keep socially distanced. Keep wearing your PPE, okay, your fluid resistant surgical mask, your visor, your gloves. When you're together in the staff room, have a minimum amount of people together at lunchtime. If you can spread yourself around the practice when you're having your breaks, eat your lunch, put your mask back on. Okay, it's really, really important that we think about what we're doing, and we're thinking about, excuse me, about our colleagues at work and about our patients. So if you have somebody in the practice who is a contact, they've been contacted by test and traced and they are a contact, that only means that they self-isolate. It doesn't mean that they go, oh, well, I've been at work. So you don't get contacts of contacts. Okay, so if you are a contact, then you will be asked to self-isolate. So we'll just leave it at that, because again, it's almost like who you talk to and who you get this information from. Test and trace will escalate it to the next tier, which within healthcare shouldn't do anything with our business. But please take it seriously, keep away from each other and keep wearing your PPE. Okay. So practice registration then. I've said that I'm really going to be talking about England, thinking about Care Quality Commission and what we do. I have to say it's not hugely different in Northern Ireland with the RQIA, or Wales with Healthcare Inspectorate Wales. They all have a regulatory arm. Scotland have Healthcare Improvement Scotland and SDCEP as well, but I am going to be talking mainly about England. So what it means to us then with that CQC registration, it means that we have to have a safe, clean environment with appropriate decontamination. Now that line there comes from the Code of Practice, which the Code of Practice for the Control of Infections and Related Guidance looks at the wider aspects of infection prevention. So that's as far as it goes. We've got the HTM, which takes us step by step of this is what you do next, then you do this, then you do this. And the Code of Practice just looks at that broader aspect. Okay, you need to have policies and procedures in, and the HTM say these are your policies and procedures. So we've got that emphasis on quality management and self-audit. So the quality management is the checklist that you have each day in the surgery. So all of the things that you do on a daily basis. Make sure that you have and know who is your decontamination lead within the practice. Every practice needs a decontamination lead. It's one of those sort of legal responsibilities. They should then, at the end of the week, countersign those checklists from the nurses, and then the domestic cleaner as well. So whoever comes in and does your domestic cleaning, they should have a similar checklist of everything that they do each day, where they clean, how they do it. And then at the end of the week, the decon lead should be countersigning that as well. Now the self-audit, we do the self-audit a minimum of every 6 months. So you'll see on the right there, you've got the picture there of the IPS audit, the Department of Health Infection Prevention Society audit. It's the toolkit. You can just Google it and download it. Now the thing with this is, you know, you're probably going to be nigh on 14 times that you've done this audit. And you'll be ticking the same boxes in the same way because you know what it is and you've done it every time. I would say change it up. Okay, CQC, your inspector doesn't mind what audit you do. Okay, it doesn't have to be the IPS audit. So if you're a member of iComply or Denplan or Appeline, you know, these compliance companies, if you're a member of them and they do an infection control audit, do that one. Do that one, and then 6 months later do the IPS one, and change it around, change it up. There's nothing stopping you creating your own, although I really wouldn't. I wouldn't create your own audit. Just use one that's, don't reinvent the wheel. Use one that's already written and already there for you. All I'm trying to say is you don't have to use the IPS one. You can change it up and use a different audit tool if you wanted to. Most important thing you do, and we'll discuss this at the end of the day with the audit section, is make sure that you do an audit report afterwards with a potential action plan. Although quite honestly, after 14 times of using it, there probably isn't going to be much of an action plan. So those are the two main documents there at the bottom: compliance with HTMO 105 or equivalent guidance wherever you are, and then the code of practice for the control of infections and related guidance. Those are the two main documents that we use. So immunisations then, hepatitis B. Surgery work, I'm not really talking to hygienists, therapists, dentists, really nurses. Surgery work can begin after the first dose. You must have that initial training and there must be a risk assessment. So all you have to do is go to the BDA advice sheet A12, which has been recently, very recently updated. Within the last year, it's been updated. Have a look at that, and that will tell you that surgery work can begin after the first dose. Now, unfortunately, the HTMO 105 says that after seroconversion, a nurse can carry out decontamination duties. You've got a choice there. You can choose the express version of the Hep B vaccination process, where you can have it all done within 21 days, or you can just allow it to take 6 months for the Hep B vaccination regime, and just do decon after the 6-month regime. With Hep B, the most important thing is to have those 3 vaccinations, one a month after the first one, and one 6 months after the first one. So you have it at 1 month. So you have it initially, next one at 1 month, and then next one at 6 months. Most important thing of all of that is the blood test between 1 and 3 months after the last injection. And that will show your seroconversion. Seroconversion, your titer levels, in order to seroconvert, must be over 100. Never again will you need your titer levels checking. Never again. Unfortunately, there are some places that say that you go and join them and they want you to do they want a blood test to check your titer levels. There is absolutely no point. If you've got that certificate, please, on pain of death, do not lose that certificate to say that you have seroconverted. Okay, you keep hold of that, frame it, do something with it, but never lose it, because actually over the years, naturally, those titer levels will just drop. So there is no point. If I was to take a blood test now, gosh, 18 years ago, my titer levels were 63. I seroconverted initially, went to have a booster, and she said there's no point, absolutely no point. You seroconverted, you're deemed now to be done for life. Okay, so science has told us, we always used to have a booster every 5 years. Now, depending, I'm going to give you both versions here, because unfortunately both versions are still in play, especially when I talk to foundation dentists who are at this 5-year point. The Green Book, chapter 18 of the Green Book, which is where we go to for our healthcare immunisations, says that we have our regime of 3, we have our blood test, then we have a booster at 5 years. Now, if you go to occupational health and they say, here's your booster, you go, thank you very much. If you go to occupational health and they go, well, you seroconverted 5 years ago, you don't need a booster, you say, thank you very much. Both are correct. Actually, the second one is more correct, because science has told us that what happens if I was to be exposed, so my titer levels, I already said to you 18 years ago, were 63. What happens is if I was to be exposed to the Hep B virus, I get what's called a second immune response. So those memory cells kick in, my titer levels will raise and they will fight the virus. And this is what happens with memory cells. So Hep B, we don't need a booster and we don't need titer levels checking. Okay, your titer levels will wane. It's a shame that some places, you literally just have to Google it and you can present to whoever it is that wants you to have your titer levels done. You can present that to them and say, look, this is the science. This isn't my opinion. This is the science. I don't need my titer levels checking. So please, on pain of death, don't lose that certificate that says you've zero converted. In the main, though, we have lost access to, I should really put there, NHS occupational health services. Now, if you're a dentist with an NHS contract, you indeed can access NHS occupational health services. The rest of us will have to pay. Now, it could well be that you see the occupational health services that you've always seen, but you just pay privately for it. It could be that you'll have to go to an independent occupational health services. The one we use at our practice and many people use is Heals Medical. You can use any of these occupational, I think the Wessex Trust do a private service as well. All I'd say is if you are going to shop, and what I would say is find out now, not when you need it. So when you go back to work on Monday, check your access to occupational health services. And as I say, it'll be that if you've got dentists with a contract, they'll have it, the rest of us won't. But what you don't want is somebody with a needle stick and you going, yeah, I have no idea where to ring. So if it's out of hours, and you'll love this, by out of hours, I really mean after 4 p.m. in the afternoon, then you can absolutely just go to your local A&E. They normally triage you first because it's quite quick. And what we want to do is get a blood test taken to make sure you don't already have Hep B, get your booster done and get you on your way instead of loitering around the waiting room. So after hours is normally after about 4 o'clock. The rest of the time, choose whether you're going to pay for an annual membership. And it's quite steep, I think, in my opinion, it's quite steep. You can pay, it's normally around about £500. But then you have to pay ad hoc as well. So that £500 doesn't cover you. It's not like an insurance. That £500 just says that you're registered, so let's say with the Wessex Trust Occupational Health that we've got locally. Or the likes of Heals Medical, you just phone up and say, we've had a needle stick. They'll do a risk assessment over the phone with you, which will normally cost you. And then they'll send you to somewhere local to go and have whatever it is after the risk assessment that they deem necessary. So a blood test is about 50 quid, Hep B is about, booster is about £70, that type of thing. So that's the sort of price range-ish that you're looking at. Non-responders, we can be a non-responder and work in dentistry. We normally have various hoops that we have to jump through though. A non-responder is classed as somebody having titer levels below 10, and a low responder is somebody who's said to have titer levels between 10 and 100. So non-responders, we'd need a risk assessment done, make sure that the person understands the risks, and normally they have to have blood tests just to make sure that they aren't carriers of Hep B. But again, that will be gone through with you at your occupational health visit. So yeah, actually mumps and measles is on the rise. Thanks in part to what's known as the Wakefield cohort. So any of you who remember back in the late 90s, early 2000s, Andrew Wakefield said that there was a link between the MMR vaccine and autism. So that prompted a lot of parents to consider having the MMR, to not have the MMR, or to have them in single vaccinations. It was a horrible time, actually. My firstborn was 2002, and I had to decide whether I got him done or not. Vaccinated, that is, not the other type of done. Vaccinated. I did choose to have him vaccinated because when you look at measles, measles can be fatal. Mumps is not very nice, can cause sterility in boys, but measles can be fatal. And the last thing I wanted was to be in A&E with a child with measles and be asked, has he been vaccinated, and saying no. But there were plenty of parents that didn't. So those children now are going to college and university. where they are not benefiting from herd immunity. And so therefore there is a spike in cases. I will say though, if you go onto the Office for National Statistics, you will see over the last couple of decades there have been spikes. Not quite like the mumps one though, which is a pretty hefty spike, I must say. So there are other things around as well. So we don't just really think about COVID. We really need to think about others. And then we've got TB as well. So back in 1995, the UK stopped their blanket TB vaccination programme, and mainly because the World Health Organization is interested in countries that are greater than 10 in 100,000 cases of new or recurring cases. 10 in 100,000 people of new or recurring cases. At the moment, the UK is 8. So we have 8 people per 100,000 that have new or recurring cases of TB. Occupationally, we are not at risk of TB. So if you have anyone in the practice who was born after 1995, you'll find that they may not have had their TB vaccination. And again, I'm really talking about nurses, because dentists, hygienists, therapists, once you go to uni, you tend to get stuck with everything, don't you? And so it's really nurses where they haven't been to uni, potentially, certainly from a healthcare point of view, and may not have had their TB. The ideal time to give a TB vaccination is childhood, and you'll find that most people had their vaccination in childhood. They were then tested again at school when they were about 12, 13 years old, and they had the HEEF or the Mantoux test, the skin prick test, to see whether that was still in their system. If it wasn't in their system, they got a booster, and if it was, that was it. They were left alone, unless you join the Royal Navy, in which case you get tested again, and I'm sure university as well. So if you've got anybody born after 1995, likelihood is they won't have had it, but it's said to be the most effective in sub-16-year-olds. Between 16 and 35, it's said to be less effective, and over the age of 35, it's said to be completely ineffective. So have a think about that if you get any sort of occupational health checks. You know, if you've got new nurses starting that are going for their Hep B, they may say, well, you haven't had your TB and you need it. Occupationally, we're not at risk. We would have to be working over a TB active patient, so a patient coughing, spluttering, TB active patient in excess of 8 hours to be at increased risk. And that's not likely to happen. Now, if you were, 8, 10 people living in one room together and one person has TB and you're living together, then yeah, actually everyone's at greater risk. But occupationally, we're not said to be at risk. And according to the World Health Organization, these are the top countries that are, where you can see how many cases, the numbers per 100,000 people of new and recurring cases that you've got there. You can see the UK at the bottom with 8, and the others are, these are the top countries from the World Health Organization. So you may find that health visitors vaccinate babies in the UK, that the family comes from one of these high-risk areas in the world, because the likelihood is you'll take the baby home to meet extended family, or extended family will come over to the UK to meet the baby. So you do find in some areas and in some sort of cities as well, health visitors will indeed vaccinate the babies. So we've got 2 levels of requirement in dentistry for infection control. We've got essential quality requirements and we've got best practice. So if you're in a practice where you don't have a washer disinfector, then you're at essential quality requirements. All right. If you carry out decon in the surgery, which you are perfectly able to do, then you're at essential quality requirements. If you've got central decon, central storage, but no washer disinfector, you're still at essential quality requirements. So what essential means is that your instruments you have are free from visible contamination. You've got some sort of validated decon, that you can prove that your instruments are sterile at the end of the cycle, and then maintained in some sort of acceptable condition to point of use. So whether that's pouched or covered storage, okay? And then we do need a detailed gap analysis to best practice. And really it's, are we going to get a washer disinfector? Yes or no? If yes, when? Are we going to have central decon? That type of thing is what the CQC may want to see with regards to what's your thought process? How are you thinking about moving towards best practice, or if indeed are you? And you could very easily say no. Now, if you are the decontamination lead or you've got a decon lead in the practice, then really they should be carrying out spot checks, going through the surgery, checking that the instruments are pouched, the pouches are intact, the pouches are dated, the pouches are in date. Also having a look through the vision packs and seeing that there's no debris on them, that they are clean. And making sure that the materials are in date in the surgery, and that the surgery is clean. So you should carry out just once a month, have a look in the surgery and just check all of those things. So validation then. So I've said that we've got to have validated decon, and we need to think about the things that we validate and how we do it. So validation is a record of a process, and it's recording that that process is working correctly and consistently. So we don't want the foil test to sometimes work on the ultrasonic, but not always. We don't want it to, the foil test to work on parts of the ultrasonic bath, but not other parts. So we validate sterilizers, we've got data loggers, printouts, that must be done daily. Helix or Bowie Dick if it's a vacuum autoclave. Ultrasonic baths, making sure that the fluid is changed twice a day, weekly protein test, and foil ablation test, cleaning efficacy test quarterly. Washer disinfectors should have protein test weekly. Some of them have got data loggers as well, and then the cleaning efficacy test as well quarterly. And keeping those records, we keep those records for a minimum of 2 years. So at this point, if you've got loads, you can go and get rid of them. So logs are kept for 2 years. And then we've got best practice, which is everything as was before. And you've got that validated washer disinfector, the central decon, and then some sort of central storage, safe storage for your instruments, whereby the nurse will take a look at her day list or his day list, get all of the packs out, take them to the surgery so that they're there, which is fine. That's not a problem. Until the dentist or the clinician even utters those immortal words of, "We'll just do that now for you." And the nurse looks at them as if to say, "Yeah, you won't, because I haven't got a pack for it. That means I'm going to have to schlep right to the other end of the building, get you a pack and come back." And that is where they start sort of closing drawers a little bit more loudly than they did before, and cupboards. And you might get the odd huff and puff as well. But all I can say is you brought it on yourself. It's fair warning. It's fair warning. So some people like central storage for instruments, but it does then rely on all clinicians using the same instruments, and we know that they don't. So then you could have a greater number of instruments because you don't know who's going to get the pack, which could increase the decontamination loads and times. So on to my favourite slide of all time. I really need to get out more. A fundamental and motivating factor to cross-infection control is self-preservation. Look after ourselves, and the knock-on effect is going to be that we look after the patient as well. So this is the chain of infection, as I say, one of my favourite slides, because actually this is what drives us. This is what drives us all the time in what we're doing, is making sure that we're not moving infection from one place to another, to another person. And this is what the mainstay of what we do, the mainstay of what nurses do every day. And I'll say it now, and I've said it throughout the whole of the pandemic, is that you could not choose to go to a cleaner place than a dental practice. You really couldn't. Dental nurses are machines when it comes to cross-infection control, and I think it's an often overlooked part of their skill set, or appreciation, an overlooked appreciation of that skill set that they possess. When you look at the hospital environment, you've got nurses there. Those nurses look after the patient. You've got somebody else that comes in and cleans the ward. You've got somebody else that comes and takes the instruments to central sterilisation. Whereas in a dental practice, you've got one person making sure that all of that is done correctly and consistently, and that's the nurses. So big shout out to the nurses. They are fantastic at this and so quick. So at the top there of this chain of infection, you've got the infectious agent. You've got bacteria, virus, fungi, whatever is living, growing, reproducing. Okay, so you have microorganisms that are harmless, and you have pathogenic microorganisms. So when I talk about microorganisms, I really am talking about the pathogenic ones, the ones that are able to cause disease. Okay, so whatever you have living, growing, reproducing needs the right reservoir, it needs the right conditions, it needs the right little environment in which to do it. And those reservoirs are in people, on the equipment, or in the water. Is what we deal with in healthcare. And those reservoirs have got to be the right conditions as well. And those conditions have to be warm. And the word that should be stricken from the English language, moist. I have been given the nice new word of humid, which I much prefer. So warm and humid are just the most wonderful conditions. Bacteria in the right conditions can double in numbers every 20 minutes. So you can do the maths on that one. So people, equipment, and water, those are the reservoirs. The whole raison d'etre of pathogenic microorganisms is to colonize, is to grow, is to reproduce. It is then when there's enough numbers of them, they go, right, let's go party, let's get out of here. Okay, so safety in numbers. The more numbers there are of microorganisms, the more likely it is that they could cause disease. So once they've colonized and reproduced to a sufficient number, they now need a portal of exit. They need a way out. They need a way of leaving the reservoir that they are in. And that portal of exit could be excretions, secretions, skin, or droplets. Once it's found its way out, it now needs a means of transmission or a means of transportation to get from one host or one place to another. And that could be direct contact, ingestion, airborne, fomites. Once it's out there, it now needs a way back in again to somebody new. It needs a portal of entry. And those portals of entry could be mucous membrane, GI tract, respiratory tract, or broken skin. And then once it's managed to complete all of that chain, the host that it lands in or on has to be susceptible. And this is where I talked earlier on about micro exposures. So Dame Sally Davis, the previous chief medical officer before Chris Whitty, said that we're too clean. In life, we are too clean, not in surgery, we'll carry on being nice and clean there. And we're not allowing children to be exposed to microorganisms or muck or soil or dirt in the same way now as we were sort of 30, 40 years ago. I don't mean sort of, you know, pop your kids out in the garden for winter. I don't mean that. But, you know, I do, and we still have the 10-second rule in our house. 10 seconds, you know, drop it on the floor, pick it up, away you go. We had to lower it, got dogs, had to lower it to 5 seconds. but they were French bulldogs, so 5 seconds was plenty. And then we've got a Labrador who kind of gets it now before it even hits the floor. But even science has said that food is in the same state 30 minutes later. I mean, 30 minutes to me is a bit like foraging. We don't really need to do that, but you know, drop something on the floor, blow off the dog hairs, in it goes. Not a problem. So best way to strengthen your child's immune system is, I totally understand about the COVID situation, washing your hands more frequently, you know, 20 seconds and what have you. I entirely agree with that, but let's not let that get away in the way of life as well. So if we've been to places where, you know, there's been lots of other people, then absolutely we're washing our hands, we're doing, but in our own home environment, that is slightly different, where it's just us, or it should just be us. And dogs are a fantastic way, cats as well, not quite as nice as dogs, but dogs are a great way of protecting the immune system. And really, when we look at that chain of infection and that host susceptibility, this is where I go back to the micro exposures I talked about right at the very beginning. Where we get those micro exposures, what happens is our body builds up this resistance, if you like, to what it's met. So when we do meet it in greater numbers, our body goes through its little Rolodex and goes, yep, I've seen that before, send in the cavalry. And we tend to be a lot healthier than our non-dental or non-medical counterparts, because actually we don't just meet one thing and that's it, we're struck down. Actually, these micro exposures give us that ability to fight off a huge amount of infection. So breaking the chain, and so we know what the chain is. Now we want to break that chain. We want to ensure that nothing moves from A to B. Okay, so the infectious agent, actually there's not much we can do about that. A, we can't see it, smell it, hear it, taste it. But I think it's sufficient to know that there are more microorganisms in the mouth than there are people on the planet. So we already know that day to day we are dealing with a potentially infectious agent. Not all the microorganisms that I said are bad, unlike the people on the planet who some crazy. So we just have to start from a standpoint, as we have always done, is treating every single person as if they are infectious. It's just the easiest way to do it. So now let's look at the reservoirs. People. Well, we don't want people in the practice who are incredibly sick or incredibly poorly. Now, I do know that at this time, we are screening our patients the day before they come in for their appointments. We're asking the patients when they come in, you know, are you fit and well for you? Have you been in contact? Anyone in your family or your household, you know, tested positive? We're asking all of the questions. We're risk assess. That is a risk assessment. We are risk assessing the person that we have in front of us. Now, with regards to COVID, the worst that we'll have in front of us is an asymptomatic or pre-symptomatic patient. Okay, that's the worst. And then that falls squarely with, let's treat everybody as if they're infectious. Okay. I'm not playing it down in any way, shape or form. I'm just sort of giving you that sort of level playing field of where we have always been treating everyone as if we're infectious, which is one reason why I personally think that dentistry has not been disproportionately affected directly by patients giving us COVID. So people, but that could go for diarrhea and vomiting bugs. It could go for chicken pox, cold sores. It could go for any type of, we don't want people in the practice who are incredibly sick or poorly. So we're not just talking COVID, we're talking about lots of different things as well. Equipment. Well, we sterilize what we can and we disinfect what we can't. Disinfection is just the reduction down in numbers of microorganisms rather than killing or removing all of them. So if we disinfect the surfaces, and we'll talk about disinfectants in a minute, if you swab the sides afterwards, likelihood is you've got microorganisms there, because actually it's sterilization that we know will kill microorganisms, which is why you've got detox and you've got the sprays that are advertised on TV that say kills 99.9%. They can't say it will kill 100% of a commercial product. because that's sterilisation. And then, yes, so we disinfect, we sterilise what we can and we disinfect what we can't. And then water, Legionella bacteria lives perfectly happily in water, doesn't cause anyone any harm whatsoever until it comes out in an aerosol, which is kind of what we do every day. So we would normally put something in our water line, and again we'll talk about that in a moment with regards to sort of cleaning day-to-day items. So we're trying to remove all aspects of possibility of reservoirs. And then we've got portals of exit and entry. Well, that's PPE and RPE. Respiratory protective equipment is one level higher than just general PPE because it's got a stronger and harsher hierarchy of controls when it comes to RPE than it does for PPE. So portals of exit and entry, PPE. And then host susceptibility, well, we don't tend to see incredibly susceptible hosts, and really what I'm talking about there is patients who are incredibly immunosuppressed or are surgery, burns, neonates, that type of thing. When it comes to our SOPs and perhaps treating patients who were had the label of shielding, who are now clinically extremely vulnerable, we may see those as more susceptible. So our SOPs may suggest that actually they'd only be coming to, so we'll be triaging, we'll only be seeing these patients if their clinicians say, yes, they can come in to the practice. We may wish to then see them as the first patient of the day, so you haven't got a lot of people coming in and out of the practice, so they meet less people, they meet the fewest amount of people that they can, or the first patient perhaps after lunch, that type of thing. So that's the chain of infection, and that's how we're breaking that chain of infection. So as I say, it's still very sadly is still one of my favorite slides, because it's what we do, and it's what we're responsible for doing every single day. So onto PPE then. If it's provided, it must be worn. I'm not really going to get into who's responsible for paying for it. Suffice it to say that if you are employed, you do not pay for it. For those who are self-employed, I'll leave that between you and the practice principal or the owner. There are various things surrounding that. So it includes mask, goggles, visor, gloves, apron, shoes, and to some degree uniform as well. Where appropriate, where you need to, treat it as single use. Have enough uniforms, spare uniforms and enclosed shoes, and probably leave your shoes at work rather than keep taking them home with you, so that you have got a separate dedicated pair of shoes at work. Claim your tax relief from the Inland Revenue. You can do this in one of two ways. Do it yourself, do not use a company. It's very simple to do. You can phone up the Inland Revenue, make sure you have your national insurance number to hand, and who you work for, which I know sounds strange, but if it's a limited company, make sure you've got the name of the limited company. And tell the Inland Revenue that you work in dentistry and you'd like to claim your laundry allowance. It should be, don't let them do it lower, it should be the tax relief on £120 a year. They may ask you if your uniform's got a logo on it. Tell them that it has. They're not going to ask for a selfie or anything, and it's not lying per se, because what they want to do is just make sure that you're not wearing, jeans and a t-shirt to work and you're claiming your laundry allowance. I'll talk a bit more about that in a moment. If you haven't claimed your laundry allowance, you can claim for this current year. So that started on the 6th of April, you can claim this current year, and you can go back 3 years and claim as well. You can also claim your GDC annual retention fee and your indemnity insurance too. So whatever you've paid for GDC annual retention and whatever you've paid for your indemnity insurance, you can claim the tax relief on both of those. And for that one, you can claim the current year, and you can go back 6 years. So if you claimed it now, you'd get 6.5 years worth. And if it's enough, they'll send you a check If it's a small amount, they'll just adjust your tax code so that you earn more before you pay tax. So obviously you've got to be a taxpayer. So if you only work 10 hours a week or something and don't pay tax, then sorry, it's not for you. But you will know it's done because your tax code will change. So you can either call the Inland Revenue or you can do it online. I think if you do it online, you've got to have the government gateway. I was going to say membership, but it's not membership, password and what have you. So give them a ring. They're not very busy at the moment. It's fine. It's your money though, claim it. That's if you're employed. All gloves that you use should be CE kite marked. Latex alternatives, you can still use latex, but we're really moving towards nitrile. Have heard of more people being allergic to nitrile now. And it's normally the dye or the accelerant that's in the gloves. So you can buy nitrile gloves that are colour and accelerant free. They're single use, don't use alcohol on them. That sentence is there. I can hear a collective rolling of eyeballs, but that's there because I put on these presentations what people ask me. So I have had someone say, oh, if I just want to go into a drawer for something, can I just rub some alcohol gel on and go in the drawer? And the answer is no, you can't. These gloves aren't designed to have alcohol on them. It can make them brittle and put sort of microscopic tears in them that we just wouldn't see. Jewellery shouldn't be worn. You can wear a plain band, nothing with a cluster, but no watches and no bracelets either. The reason for no watches and bracelets is because it can increase the surface area and it can be one of those reservoirs for colonisation. So what you don't want to be doing is having a watch on while you're working, and then God forbid if you have to lick your watch, then it's all your fault and it's on you. So no watches, no bracelets, naked to elbow. If you need to have your arms covered, then you can get disposable forearm covers that allows you to maintain your religious beliefs and also be safe. And you can have, as I say, forearm covers that allows you to either cover your uniform or be your forearm covers. Okay, so masks. I did promise a little bit on masks. I'm not going hugely into. I'm not going to revisit Maskgate that I had in June. I'm going to leave that firmly in June. But because I think all of the fakes are out of the market now, and we're all on the genuine stuff as we should be. So, oh, sorry, I'm in the way of that, aren't I? So let's move me. Let's move me there. There we go. FFP3 masks must be properly fit tested. Anything that is close fitting to the face has to be properly fit tested by a competent person. So I think we've got enough competent people now. Right at the beginning, I'm right at the beginning, it was a problem getting test kits, fit test kits. I believe that's pretty much okay now. I do think that there are still some people that are struggling to get a fit test kit, but fingers crossed, especially if you're NHS, there should be other people within the NHS that can help you. I think it's important to say though that the masks shouldn't be ear looped. The regulations that we have say that they head straps. The Health and Safety Executive have put out a missive saying ear loops cannot create enough of a seal around the face. You can't even use those things that go around the back of your head, the ear savers or whatever they are, to make it tighter, because the RPE, which is what this is, should be in its entirety untouched. So you shouldn't, for example, you can see the 3M Aura that's in this top right hand circle here. You've got elastic straps there, non-latex elastic straps. For example, you couldn't put a knot in one of those to make it tighter. If it's not tight enough, it's not for you, because you can't guarantee that you'll get that knot the same size every single time. So RPE should remain unchanged. which was part of Maskgate as well. With any tight-fitting respirator mask, which is what these are, you should have a break every hour. So every hour you should take it off, reoxygenate, rehydrate, put it back on, just a couple of minutes. I'm not saying go and take a half-hour break. It's just a couple of minutes. You should just be able to reoxygenate, rehydrate, and just take a break from the inside of that mask. That mask should not be put on at 8 o'clock and taken off at 12 or 1 o'clock. Okay, it should be, and that's in the regulations, that's in HSG 53. So if anybody goes, oh, I've got to wear it all the time, my boss says I've got to, or, you know, I've been told I've got to, HSG 53, which is Health and Safety Guidance 53, will tell you 1 hour you can wear that for. Now, don't worry if the endo that you're doing is taking an hour and a quarter, an hour, 20 minutes. What I mean is don't put it on your face at 8 o'clock in the morning and take it off at 1, all right? That's not how they're designed to be worn at all. So you can use the disposable type, there's the 3M Aura here. Other brands are available. Other brands are available. It's just a good Google image. And then you've got the likes of these reusable, so these P3 masks, particulate 3 filter masks, like you've got the JSP Force8 Press to Check, so you just hold the filters, breathe in, and it should suck out the contents of your nasal cavity. Or you've got stealth masks, or you've got ellipse, there's lots of different types of P3 masks that you have. Don't share them. Don't share them. They should be yours and yours alone. You can fit test the same mask, but it should be thoroughly cleaned in between. But that mask should just be yours, and don't be putting smiley faces on. You can see that this JSP Force8 right in the center there is the exit valve, and that exit valve should be covered. So which is why we say for the reusable masks, choose the non-valved masks, because then everything you breathe in is filtered, but everything you breathe out is not filtered. Okay, so fine if you work on a COVID ward, because you can't make them any more sick, but fine if you work on a COVID ward, we don't. So exit ports must be covered. Now, we did have the fact that, oh, that shouldn't say session, by the way. So these disposable masks, non-reusable, sorry, let's say non-reusable, which means they can be used for a shift. I've written session there. It's not a session, it's a shift. So FFP3 can be used for a shift during COVID. Your fit tester will tell you how to put them on and how to take them off safely. For the sort of shift wearing, 8 hours is a shift according to the Health and Safety Executive. So your fit tester will tell you how to safely put them on and take them off, so that you're not sort of folding them all in and touching everywhere and yucky stuff like that. Fluid resistant surgical masks. So during the pandemic, I'll pop myself back over there. Excuse me. At the beginning of the pandemic, pre-COVID, our masks were always single patient, single use. And now they're saying that you can use them for a session and then replace them. Just keep your eye on the current guidance, because as the supply chain eases, we're going back to single use. But it still means that we've got to have a mask on while we're walking around the practice and while we're talking to patients and talking to each other as well. Excuse me. Face masks. So if you're using the two that are on the left-hand side there, always sort of take off from behind the ears or break the straps at the back. Just don't touch the front, because potentially this is where we have stuff. And we do touch our face 20 to 30 times an hour. So we need to wear something that's comfortable. And certainly when I do fit testing, I find that people put them on and then they start adjusting them and start playing with them, and then they start wearing them around their chin or on their heads. Please wear it for how you've been taught to wear it. Okay. Once it's on your face, don't touch it. Leave it alone. Quite hard to do, but leave it alone. Visors. These should be used during all clinical and decon procedures. Wear them over your own glasses. Your glasses aren't, if you're just wearing reading glasses or spectacles, they aren't deemed to give enough coverage for the work that we do. So you should be wearing either a visor over the top, or safety glasses, or having prescription safety glasses. Again, back with the plastics, I don't really like visors as being single use. They can be wiped down in between patients, inside and out, and change when they're scratched. When you can't see out of them anymore, change them. Again, just thinking about the plastic waste that we're doing, and just taking care not to touch the outer surfaces that could have splash on them. I briefly touched on plastic aprons earlier. They should be used during all decon procedures, and I have known CQC have a look in the bin in the decon room or wherever you carry out decon, just to see how many aprons are already in there from before they came in that morning. It also says during COVID where risk of contamination is likely. So I was nursing at the beginning of the pandemic, and I very quickly realised that I'm wearing a plastic apron, but I'm over by the computer. So my back is to the patient and the dentist, and I've got that little thin strap of plastic around my back, and I'm thinking that's really going to protect me. So very quickly thought, well, I'm going to do a risk assessment to actually see the validity of wearing them. And then they came out with only where contamination is likely. So you'd have to consider what that is. But you can already see on the picture there, it doesn't cover your neck. And if you're a dentist or a clinician that's sat, you've got a patient reclined in the chair, actually where the patient head is and where your legs are underneath the chair, there's very little of you that's protected by a plastic apron, very little. And I just think about the horrific impact on our planet. So when you do wear them though, break it at the neck, break it round the back, and then fold it in on itself so that you're not touching the outside, but you're just folding it in from the inside, and then put it into clinical waste. Oh, sometimes people are saying, well, I don't have an impact on the planet because my single-use gowns for AGPs, my single-use aprons, my single-use visors, my single-use everything gets incinerated with my infectious waste. And honestly, I could probably guarantee that watching this webinar, that I could probably bet my firstborn, I quite like him, I could probably bet my husband that you have orange bags in your practice, so that your hazardous waste goes into orange bags. Now, when you have a look at the HTMO 701, anything in an orange bag can be incinerated, absolutely can be incinerated, or it can be treated and sent to landfill. So the orange bag gives your waste carrier the option of incinerating it or autoclaving it or chemically treating it and then sending it off to landfill. So just because you think that your stuff is being incinerated, it might not be, because I can guarantee you've probably got orange bags. The Public Health England have done quite a few posters, a couple of videos and what have you on how to safely put on and take off both PPE and your enhanced PPE as well. Taking uniform to and from work, and again, the dental appendix says put it in a disposable plastic bag. Oh God, who wrote that? Who wrote how much plastic in one dental appendix? Don't. Put them in a pillowcase or in a cloth bag, and then when you get home, all goes in the washing machine. Now, what you'll probably find, I've done a couple of straw polls while I've done some sort of in-house training and stuff, and most people sort of go home, take their uniform and put it into the washing machine on its own, without the rest of the household stuff at the hottest temperature for that fabric. And that right there is the reason that you get your laundry allowance, is because actually we are supposed to be laundering our uniform on its own, so we get extra money for having the washing machine running on its own without anything else in. So put it into a pillowcase or into a cloth bag, go home and just chuck everything, including the bag or pillowcase, into the washing machine. Leave your shoes at work and try not to bring unnecessary items into work as well. Don't bring in what you don't need. So what do we use then as disinfectants? So now thinking about that chain of infection, and thinking about the equipment, the sides, not the equipment because that gets sterilised, but thinking about the sides, the chair, the light, and all of that sort of thing. Again, please ignore the products, they're just good Google images. So we can spray with biocides or use impregnated wipes. The likes of, what's that, Microzid. Actually, it doesn't matter whether it's Microzid or BioClear or any other type of spray disinfectant that we use in the practice. If you have a look at the manufacturer's instructions, it says that the contact time, the time at which that needs to be in contact with any potential microorganism, can be anything from 30 seconds to 12 to 15 minutes. So we don't, in normal times, we don't tend to have that type of time. I think people use the biocidal sprays incorrectly as well. They spray onto a tissue in the vain hope of reducing aerosol, but spray into a tissue, then wipe the side down. I could probably just lay down a challenge for you. Spray into a tissue, wipe it on a side, and find out at what point it's dry. Okay, these sprays aren't designed to be used like that. They're designed to spray onto a surface, wipe the surface, break up the colonies, remove visible debris, then spray it on again and leave it. And when you're leaving it, that's your contact time. Okay, that's the time in which you need those biocides to work. We've got impregnated wipes as well, which I have to say, the shift over the past sort of 5 or 6 years has been towards the wipes, because you don't have the aerosol to contend with, but also it's a one-stop shop. Use the wipe, breaks up the colonies, removes any visible debris, and leaves a residue behind it as well. But we do have a new kid on the block. I say new, I've been banging on about it for a good couple of years now, and that's hypochlorous acid. Again, ignore the fact that that's Salvarsan there. You can use Dentagard, Clean Cert. Gosh, there's a few manufacturers of hypochlorous acid now, and its claim is that it kills all known pathogens in less than 1 minute. And that's normally at 100 parts per million. Go up to 200 to 20 parts per million, and that goes down to 30 seconds. You can drink it. It's natural, it's safe. It is tap water and salt electrolyzed. Has a slight bleachy smell, which I think is good in a healthcare environment. It's wet because you don't have any type of alcohol, or you don't have any type of thing that will make it dry quicker. But the fact that we're having gaps in space in between patients normally means we've got that type of time anyway. This one that I've got here is Optizil from Clean Cert. And you can see there it's got its right BS number and enveloped viruses and things like that. Just have a look at what it is that you are using. You can get machines that will make the hypochlorous acid. It's not stabilized, so you'd have to do that every day. But it has several uses as well. So you can use it as a skin preparation before Botox fillers. You can use it as a hand sanitizer. You can use it as a cold sterilizing soak, so impressions before they go to the lab, when lab work comes back as well. Obviously hard surface disinfectant spray. You can use it as a shock system for your water lines. You can put it in, leave it for 40 minutes and rinse it out. And again, there is no sort of onward effects to any patients there when you use it as well. So a little bit of a one-stop shop, hypochlorous acid. So have a think about changing to that if you haven't already. So storage and transport, we know that we've got our pouched items. We can store those for 1 year in a pouch. Covered storage, we've either got 1 day in the surgery or 1 week outside of the surgery. So sometimes when you have a look and you've got quite a few exams in, then you might just want a tray with a load of mirror and probes, or a clippy box with mirror and probes, lid on, in the cupboard, setting up for the next patient, open the box, take out your mirror probe, perio probe, lid on, put it away, and away you go. So we can use covered storage, and that's 1 day in the surgery and 1 week outside of the clinical environment. So the decon room, you can leave it for a week in there. You'll just have to have a protocol of when they got sterilised. So most people that I speak to that have got covered storage, on a Friday afternoon, they'll just reprocess all of the instruments that are there, so that then they're good for another week again. Or they'll pick an afternoon, perhaps where there's, one surgery is not working and you've got, the manpower to actually do that. Transportation to decon room. So you'll have your dirty boxes, or your radiographs, to take those to wherever you process them. If you've got phosphor plates and you've got a central place to process the radiographs, it's all just about not leaving the surgery with your gloves on. Okay. So if you've got a radiograph that needs processing, then on the side in the surgery, put a wipe down. As the clinician has taken the radiograph, they put that onto the wipe. You, with your gloves on, then clean that and either put them into a small clippy box or a steri pouch or something. Take your gloves off, take that to the processing room, new gloves on, you can take the pouches off. And process those radiographs. So it just means that you're not wandering around the practice with gloves on. It's the same when you take your dirty box to the decon room. You've got your box, wipe or spray down the outside of the box, take a paper towel, wrap it, walk. Okay, it's about perception. It's either your colleagues looking at you as if to say, are those gloves clean? It could be patients that are looking, going, oh, are they used? Patients do tend to notice far more than we give them credit for. So just think about what it is that you're doing and how you can safely move items from one place to another without wearing gloves. Right, cleaning day-to-day items then. So let's have a look at cleaning some of these day-to-day items. Water lines. They should, preferably, they don't have to. Okay, you can just have distilled or RO water in your water lines. There's nothing wrong with that. Then every week you shock the system. Now, shocking the system just means that you remove any biofilm that's present in the lines. Things like Legionella bacteria feed on the biofilm, which allows them to grow, to proliferate, and the surgery normally is warm. So we've got their perfect storm, a perfect reservoir. So preferably put some sort of antimicrobial into the bottle, whether it's ADEC tablets, Citrasil, Alpron. There are lots of different ones out there. Okay, in the morning, your lines should be run for 2 minutes. Okay, at the beginning of the day. That then gets moving any water that's been standing in the lines, really moves it through with some fresh antimicrobial. On a Monday, if your surgery hasn't been open since the Friday, on a Monday, open up the taps as well and just get water flowing through the practice if it's been stood still. 20 seconds between patients. Yeah, right, okay. We know we should. But it's not always practical, and actually sometimes it's not even been standing for that long. So 20 seconds in between patients. If you use something like Alpron, the bottle should stay on there overnight. It's not designed to come off the system. Alpron is not designed to be a dry line system. So if you're just using RO water or fresh distilled water, then yeah, that will come off, the lines will be dried, and that's how they'll be left overnight. Whatever system it is that you use, you decide from the manufacturer's instructions how you do it. There you go. If you're using Alpron or any other system that requires you to do a dip slide quarterly, you can do. You don't know what you're growing. You have no idea what you're growing. only UKAS laboratories are able to tell you whether it's Legionella bacteria that's growing on there. So use with caution is all I'd say. I would say use them because they're part of the Alpron system, but then you can shock the lines with something like hypochlorous acid or the Alpron kit, and then retest them for growth. But you don't know what you're growing, so use with caution and shock the system. Hand pieces. I always say the biggest problem we face with hand pieces is over oiling, is getting a little bit too enthusiastic with the oil can. So I'm going to teach you to suck eggs now, okay, again with the collective eye rolling. Do hand pieces first. So when you bring your dirty box through from the surgery, always do the hand pieces first, because then you can drain them of any oil before they go through the sterilizer. So always remove any burrs that are in the handpiece. Take a clean tissue, put it over the end of the handpiece, get the oil can with the right connector on. Sometimes we sort of spray it in the general direction of the handpiece because we haven't got a connector. Get the right connector so we get the right delivery of oil. Shake the oil can and place it onto a flat surface. Take the handpiece to the can and just do a half second burst, okay, just so you can hear the bearings going round in the end of the handpiece, just so you can hear it whiz, all right? Then check the end, check the tissue. If the tissue's clean, just give it a wipe off and stand it upright so that oil can drain while you carry on with the rest of the instruments. If the tissue's dirty, select a clean bit of tissue, same again, handpiece on a flat surface, handpiece to oil can, half second burst, okay? And just make sure that you stand them up to drain any oil. Okay. Aspirator tips. Well, we've got the disposable ones there in the middle, and then we've got the reusable ones over on the right-hand side. We can use reusable aspirator tips. They don't have to be single use. What we would need to do though is reflect in the infection control policy how we clean them. So you would need to get a bottle brush, clean the inside of the aspirator tip, then give it a good clean on the outside, and then put it in a vacuum autoclave. Okay, so you can use the rigid ones, the reusable ones, which can actually be sometimes a lot better and a lot easier to use, especially when you've got a carpet-tongued patient. You know the patient where you have to use 2 hands to retract. We've all had those patients, haven't we? Burrs. Okay, so steel burrs, single use. They cost pennies. You will only get about 1 sterilization cycle out of them before they rust, and they'd have to go in the bin anyway, and they do blunt really quite quickly. However, tungsten carbide tipped burrs aren't single use and can be reprocessed. So the ones that have got a darker shank at the top, these are tungsten carbide and they stay sharp, and they can be reprocessed, but not with a metal burr brush, okay, because a metal burr brush will create scratches on the surface. And then I know what nurses are like. We'll use them on flat plastics and wards carvers and in fact anything, just to get things clean. But what will happen is they'll scratch the surface, increase the surface area, and then that makes our job harder each time we try and clean them. So try using a nylon burr brush, and what you can see is that metal strip that's halfway up. You can actually slide that up and down. The further up you go, the stiffer the bristles are, and that makes it much better to clean with. What I would say though is take this metal bar up quite near the top and crimp it with some Adam's pliers or something so that it won't sort of come off. And you can buy, they're about £1.20 each, and you can use them then on anything. Any golfers among you will go, oh, can use those for my golf balls. Matrix bands, a lot of people use the Omni Matrix or the single-use disposable matrix bands. Really, if you use the Squeveland matrix bands, the band has to be changed every single time, and the holder reprocessed. A suggestion when it comes to squealing matrix bands is that you put the whole thing through first. So clean it, sterilize it. When it comes out of the sterilizer, take the band off, clean it, sterilize it again, and then put a new band on. I do anecdotally hear of people cutting themselves on matrix bands when they take it off. So it either gets taken off in the surgery by the clinician, and all you do is get the holder and put the holder through, or you put the whole thing through, take the band off, whole thing through again, put a new band, new band on. Endo files, okay. Any endo file without that single-use logo on, you can see on the right there, can be reprocessed and reused for the same patient to complete endo on the same tooth. So you can't keep a set of endo files if they need the upper left 1 doing, and then they need the lower right 3 doing, and then they might need an upper 7 periodontics doing. It has to be one patient, one tooth, but only if they haven't got the single-use logo on. Anyone with the single-use logo on has to be thrown away and cannot be reprocessed under any circumstances whatsoever. Placed in the sharps box, got rid of. Some people say it doesn't actually matter what files I use, I throw them away each time. That's fine. But for the avoidance of doubt, something like ProTaper doesn't have the single-use logo on and can be reused. On the right there, you can see you've got the Kerr triple flex files, Headstrom files, Gates Glidden, yeah, finger spreaders. Gates Glidden, I found it quite hard actually to find a packet with a single-use logo on. Gates Glidden, if you still use Gates Glidden, chuck them away each time. I don't care what's written on the packet, chuck them away. Just in my experience, they either fracture right at the top where the bulb, where the head is, or they fracture right at the bottom, just above where the shank is that you put them into the handpiece. So make sure that they are chucked away. Scaler tips. So we've got the Cavitron tips on the top right here. If they go into just a plain black holder, normally you'd have a plastic sleeve over that. The Cavitron tips can be ultrasonicked. They can be ultrasonicked as long as they are single layer ultrasonicked. Don't mount them on top of each other because it can affect the blades, but they are designed to be ultrasonicked. If you just have a plain black holder, that gets wiped down in between patients. If you have the Sterimate, the black handled Sterimate, then that is designed to be reprocessed in between every patient. Okay. You've got the Pizon type tips over here on the left hand side. Any of these handles that have that 134 logo on gets autoclaved in between patients. Okay, so obviously the tips do. The tips always get autoclaved in between, but just make sure that if your handpiece has got the 134 logo on, it goes through every time, obviously along with the key as well. Do be careful that you are making sure that everything gets sterilized, that should get sterilized in between. So I briefly talked earlier about all of the plastics. Can we switch to earth-friendly items instead of plastic? And the answer is yes, we can. Promise you, you've got orange bags in the practice. Yellow will always be incinerated. So if you've got sharps boxes, they will always be incinerated, but your bags can be incinerated or they can be treated and sent to landfill. So to that end, you could use bamboo aspirator tips, which will degrade at some point at landfill. And then we've got the patient rinse cups. I have found though that not many practices are allowing patients to rinse out after treatment, and it's been going very well. So my suggestion is why not carry it on? Why not carry it on after it's all over and just not offer patients a rinse anymore? Why not? I used to work with a dentist who used to just shower the patient down with the 3-in-1. He'd 3-in-1, I'd aspirate, happy days, patient went. No need for a rinse out. think about things that we're doing now that we could potentially carry on afterwards, because just imagine what you can save. I don't mean financially. Imagine what you can save not using plastic rinse cups. Aspirator tips we've already talked about. Maybe going back to the metal 3-in-1 tips. Again, we'd be looking at a vacuum autoclave to make sure that the lumen, the hole inside, was autoclaved. Then using glass slabs instead of the paper with wax covering on, and going back to glass Dappens pots as well instead of the plastic ones. So things to think about when we run out of stock, of going, well, actually, do you know what? I mean, these glass Dappens pots are about £2 each, and they go through the autoclave. And same with glass slabs, they go through the autoclave as well. So just really thinking about the things that we can go back to. God, we're going to go back to the 80s. Music was better then as well. But we're going to go back to the 80s with all of our reusable stuff. Happy days. If any of you are a den plan practice, have a chat with your local consultant, because I happen to know that they are helping practices sort of move towards more eco-friendly and earth-friendly equipment. So have a chat with them and you might be able to get a few pointers, a few ideas, a few sort of incentives that way. Okay, so on to pre-sterilisation cleaning, and then we'll finish off with hand hygiene. So pre-sterilisation cleaning. All we are doing here is reducing the bioload. Okay, we are making something cleaner before it goes into sterilise. We are removing any debris that's on an instrument because the steam will not penetrate the debris. So the whole point of pre-sterilisation cleaning is removing any debris that's on any piece of equipment or any instrument. Okay, now there are 4 types of pre-sterilisation cleaning. Enzymatic. So if you've got a period of time that you know, actually, do you know what, first patient, AGP, I know I'm not going to get a chance to get to the decon room, I'm just going to cover them with an enzymatic spray, foam, solution, okay, then it will start breaking down the proteins so that you're not going to have something that's set and congealed on your instruments before you go and clean them. So you can have like a holding solution, a holding spray or foam. Ultrasonic and washer disinfector, really for the HTMO 105, washer disinfector is it. Okay, you have to handle the instruments less, it's automated, it should be consistent. So actually that's probably the way that HTM want you to go. We don't have to have that though in England. We do in Wales and Northern Ireland and Scotland, but in England we don't. So we can use manual cleaning, ultrasonic baths. If you use both manual and ultrasonic, the recommendation is that we take our dirty box to the decon room, or even if it's in the surgery, put all of your instruments straight into the ultrasonic, run it for a cycle, rinse off the solution, inspect them under an illuminated magnifier, and if there are any rejects, any instruments that have still got debris on, we can then manually scrub that off. Okay, re-inspect and sterilise. Try not to manually scrub them, put them in the ultrasonic, take them out, rinse them, inspect them. Ultrasonic first, because then if you were to get a Sharps injury, the instrument is then that much cleaner before it pierces your skin. Okay, so ultrasonic bath, make sure you use the right solution in it, try not to stack it too deep, and it should be degassed before it's used the first time, so all the air bubbles are out. Fluid changed at least twice a day, rinse off all of the fluid before things go into the steriliser. And then every quarter, carry out the foil ablation test, and it will either eat all of the foil or you'll get patches, excuse me, patches on the foil as shown in the picture. Washer disinfectors, cold rinse, a huge turnover of water than a domestic dishwasher, although they're very similar. You get more turnovers of water in a washer disinfector. I also, given the choice, wouldn't put handpieces anywhere near a washer disinfector. Strips them, strips the oil out of them, and can lessen their life expectancy. So keep on doing what you're doing. clean them, oil them, autoclave them. Validation, weekly residual protein test, quarterly soil test, so cleaning efficacy, and your foil test as well to make sure that all parts of the ultrasonic bath are working consistently. Okay, so cleaning instruments manually, wear your appropriate PPE, maintain a dirty to clean workflow, open out forceps, scissors, that type of thing. And this one, fill the sink with water, the right amount of water with the right amount of detergent. Okay, so if it's 5 mils per litre, then I would expect to see on the sink a fill line to a litre or 2 litres, and then some sort of measuring jug, measuring pot that says, yep, here's 5 mil, here's 10 mil, and it goes in. That's what I would expect to see. So I would expect to see a fill line and some sort of pot, rather than some water in the sink and some detergent in that water. Okay. Fully immerse the instruments, agitate, scrub with a long-handled bristle brush for this. You can rinse them in a second sink, or you can have 2 bowls in one sink, 1 bowl to scrub them, 1 bowl to rinse them. If you're going to wrap them before they're sterilised, they must be dry. So they should be dried with a non-linting cloth, inspected, pouched, and into the steriliser. If not, then just drain them, inspect them under the magnifier, single layer on the autoclave tray, and then into the autoclave. It says they're disposable solutions, but you're going to go to manufacturer's instructions. If the manufacturer's instructions say that you can use it for a session, for a day, for a week, then that's what you can do. My advice is never more than a session, never more than change it at lunchtime, empty it at the end of the day. More if it's grossly yucky. You can't carry out a protein test on manual cleaning. Okay, so I know some people try it, but you can't. Okay, so no protein test, no validation at all required for manual cleaning. HTM says that it's not as effective. That's because you've got the human element rather than automated. Can't reproduce the results. Fairly true. But there is a danger of sharps and foreign body injuries because you've got to handle the instruments far more than you would if it was ultrasonic or washer disinfector. Code of practice for the control of infections and related guidance, the wider aspects of infection prevention, 10 criterion, give it a skim read. At the beginning is the 10 criterion as they are generically. Appendix B is dentistry. It's about 5 or 6 pages long, and it applies these criterion to dentistry. Okay, and 3 of them don't apply to us. So especially if you're decon lead, if you're registered manager, have a skim read of the code of practice as well. Okay, in there is the IPC lead annual statement, the infection prevention control lead annual statement, does what it says on the tin, should be created annually, and from the grey box down, answer each of these questions. Just when you've undertaken audits, were there any actions, training, policy reviews, that type of thing. CQC do like to see this. Do like to see this. Okay. Last section then, hand hygiene and care. And again, the pictures here, the illustrations are just for illustration purposes. A mild soap, that's all we want from it. We just want it to be a surfactant. We want it to break water tension and make water wetter. Okay, so preferably colour-free, fragrance-free. Now there is Waitrose Essentials hand wash there. It's the only one I've seen on the high street that is colour-free and fragrance-free. That's why that one's there. Hand sanitizing gel, so alcohol gel or hand foam. If alcohol is too stripping and too drying on your hands, think about foam. And always using a good moisturizer at lunchtime and at the end of the day, so that keep our hands healthy. Long post of this, so it's over 2 slides. 1 in 6 mobile phones is contaminated with fecal matter. 1 in 6. And then the interesting fact is that 82% of dentists have their smartphone in the surgery. Fecal bacteria can be found on 26% of people's hands in Britain. I'm kind of hoping that these stats are a bit better, excuse me, with COVID, in the fact that people are washing their hands for 20 seconds. I think people have gone off the boil a bit with that though, haven't they? 33% of us don't use soap when washing our hands, and only 10% of people wash their hands after using the loo. And I've always said this before Boris did, is sing happy birthday twice. And that gives you that effective length of time to wash and rinse your hands. 39% of people wash their hands before eating food, and 1 gram of human feces contains 10 million viruses and 1 million bacteria. A gram is quite a lot though. You'd see a gram. It wouldn't sort of sneak up on you. It would be there smiling and waving at you. 15% of men don't wash their hands at all, compared to 7% of women. When men do wash their hands, only half use soap, compared to nearly 80% of women. And there's fecal matter on 14% of banknotes and 10% of credit cards. Thank God we can wash the banknotes now, hey? Give them a good old spray down and a wash down. So patients, they are walking germs there, and their potential for carrying and spreading nasties shouldn't be underestimated. So we kind of got to have a little bit of a reality check. What we knew we faced in the 80s was, yeah, well, we just saw patients, we didn't wear gloves, we didn't wear masks, we just saw any patients that came in through the door, quite frankly, took a medical history to make sure there were no drug interactions. Patients lied anyway, still do actually, but mid to late 80s, HIV came to light, and it scared a lot of people. It was probably, for me, the biggest change that I saw in how we worked and how we practiced, because wasn't thoroughly known how HIV was transmitted, and it was a little bit like, oh, you've looked at me, you've given me AIDS. But AIDS was HIV, rather. If you contracted HIV, it was a death sentence. It was a death sentence. You died of it. Okay, those that got it died of it. It's not like nowadays. Okay, nowadays we still have HIV. The hepatitis is down the alphabet to G or M. I can't remember where we're up to. HIV doesn't like living outside of the body. Okay, it'll last for 2 to 3 minutes, then it will die. Hepatitis A won't tend to see patients in the acute phase, quite yellow, quite poorly. Hep B, in the right conditions, Hep B can live for up to a week outside of the body in low colony forming units, quarter of a pinhead. That's all you would need, quarter of a pinhead. Hep C is the unknown one. Patients honestly don't know they've got it. So that's why we treat everyone as if they're infectious. Variant CJD, that was the theory behind the single-use endophiles. TB we've talked about. Then we've got the other coronaviruses, MERS, SARS, COVID-19. Coronaviruses are unique in the fact that they cross over from the animal chain to the human chain. They are zoonotic in nature. And then we've got these ones, Campylobacter bacteria, E. coli, C. difficile, diarrhea and vomiting bugs, herpes. Herpes is for life, not just to get to Christmas. You get to keep that one. So I think that we're exposed quite a lot. We are potentially exposed to quite a lot. And I still can't go to the vets to have his injections, to have my dog's injections. Can you believe that? We are seeing patients for AGPs, for fillings, for everything. And they won't even have the dog in the practice. So what we have on our hands then, what we're trying to get rid of, we've got resident and transient microorganisms. The resident ones live deep within the epidermis. They're part of us, they're part of our normal flora, our commensals. They keep our hands healthy, and they're not usually responsible for causing infection. So we don't want to use a harsh hibiscrub, chlorhexidine gluconate on them, because it can really damage the flora that's on there. But transient microorganisms, actually, these are the ones that are on the surface of the skin. The direct contact, go back to that chain of infection, that direct contact going from place to place. E. coli, C. difficile, diarrhea, vomiting, flu, all of those, COVID, all of those, surface of the skin, very easily removed by good hand hygiene. So I said at the beginning of this section that we want a mild soap. All we want it to be is a surfactant. So every bit of water, you can see from the top and the right-hand picture there, every piece of water has surface tension on, and it allows insects on top of water. It allows a bubble to be formed. That is surface tension. The GIF you can see on the bottom left-hand corner is just water in a dish with pepper grounds on top, and the cotton wool bud there has got soap on it. And all it's doing is breaking the surface tension. You can see all of the peppercorns moving to the outside because the surface tension has been broken. Okay, and this makes water wetter. And then it's the action of cleaning our hands that cleans them, not the detergent we use, which is why we want the mildest detergent we can possibly get, which made me laugh in the beginning of the pandemic where all of the antibacterial soap went. This is a virus, not bacteria. So hand washing, wet our hands first. Don't put detergent onto dry skin. Wet your hands first. Liquid soap, running water, sing happy birthday twice. Thoroughly rinse all the detergent off afterwards and dry with disposable paper towels. And then we can use alcohol gel straight after. Our hands are then up to about 90–95% transient microorganism free. That means we can use that gel or that foam in between patients, but there are times like these when we go back to using soap and water. So we go back to soap and water at the beginning and the end of the session if your hands are visibly soiled, or if there's a build-up of alcohol gel when they get a little bit sticky, and also after carrying out decontamination as well. So those are times when we go back to using soap and water. Now, I've got a little bit of a video here for you just to break up you having to listen to my voice for the whole time. You've done really well. It's been almost 2 hours. Centre for Disease Control in America, a bit like our Public Health England, really. Little bit of a parody for you.
We need good hygiene to keep living. Lather up for 20 whole seconds, then you kill it. How many times do the germs won't keep winning? We need good hygiene. Hygiene. Mama said to me every day, wash your hands. And don't touch your face, hand sanitizer, soap and hot water after everything, when you do anything. So you're a tough guy, like to touch the mud guy, like to keep your palms dry, cough into your hands guy. I'm the clean type, like to see it clean type, trust the CDC type, scrub the surface sheet type. I'm the bad guy. Duh. Now watch it drip. Now you wait. Now watch it drip. Now you wait. Okay. Don't touch your face. Don't touch your face. Don't touch your face. Don't touch your face. Now watch it drip. Now you wait. Now watch it drip. Now you wait. Catch that sneeze, bro. Shouldn't use your hands better in that sleep, though. If you got a cough, catch it in your elbow. No shaking hands, we can wait for hello. Don't go out, bro. We don't want to spread any more disease, so we should follow everything the CDC knows. You'll be feeling better in a couple weeks, so I mean, I hope so. I have a hands, I have a soap, soapy hands. You just got home late, cooking on your brain. You can save the day, wash the germs away. The water's gonna spray for 20 seconds while you wait. Baby, then you're gonna shake. Shake it off. Germs like you don't belong on guys like me. I'm gonna wash my hands, I'm gonna keep them clean. Yeah. Germs like you don't belong on guys like me. I'm gonna stop the spread of COVID-19. Yeah. It's all just like gold, that hot water-based combo. This ain't good and mad germs, them sad germs, that bad disease. So pitch hallelujah, 'cause don't claim phone, gon' give it to you. 'Cause don't claim phone, gon' give it to you. 'Cause don't claim phone, gon' give it to you. Bad bugs, leave out squash. Don't believe it, just wash. It ain't working nothing bad, but I'm feeling like a snack. Time to wash up, gonna make myself some magic. Now you know I'm single bound, 20-second count, that's round. Hot water, soap, rinse, lather, and repeat. Now can nobody stop this scrubbing? You can't stop this scrubbing. Yeah, I'm gonna take my hands to a won't sink flow. I'm gonna wash till my fingers glow. I'm gonna take my hands to a won't sink bowl. I'm gonna wash so these phalanges go. Wash your hands to do. Wash your hands to do. Wash your hands to do. Wash your hands. No, but seriously, everyone, I hope this finds you doing amazing, guys. This is
so that was just them plugging CDC at the end. Yeah, I hope you enjoyed that. A little bit light relief from me. Last couple of slides now. This was a you might have seen it on Facebook. A primary school teacher over in America was trying to teach children about the importance of hand washing and hand hygiene. So what she did was she took 5 pieces of bread, she took a control piece that was untouched, put it into a baggie and sealed it for a month. So all of these were sealed for 1 month to see what grew. Number 3 there, dirty hands. So she just got the kids to touch that without washing their hands, put that in, got them to clean them with soap and water and put that in, and then hand sanitizer as well. Now you can see some growth on that hand sanitizer one. And we're sort of saying, well, if you can't wash your hands with soap and water, use hand sanitizer. Now, I personally think that the reason that there's growth on there is that you have to apply hand sanitizer correctly. So you need to put it on, and then you need to still follow that 8-stage ALIF poster that you've got at work, and just getting to all of the places that you can, that you do with the soap as you do with hand sanitizer. So when you're talking about kids, they'll just squirt it on and go like that and go, yeah, I'm done. But we need to make sure that we put it on correctly and enough of it so it doesn't go on and just evaporate straight away. But number 1, oh, look at that, for a Chromebook, for a laptop. I think since I found this, I've never actually wiped my MacBook down quite as much as I do now. And you know, similarly, get in from the supermarket. I've still got my baby wipes. They're only baby wipes because we're just talking about dilution again. I've got my baby wipes. I'll wipe the steering wheel down. I'll obviously do my hands first, not with the baby wipes, but with alcohol gel. Wipe the steering wheel down, indicator, handles, gear stick, handbrake, all of those types of things, and I'll just wipe it all down once I get in the car. And I also do my credit cards and my purse as well, and my phone. Oh my God, my phone. Do my phone as well. I'm not obsessive, I promise. So to summarize then, look after yourself, and the end result will be that we take care of the patient as well. GDC standards and our Silver Book 1.9 says know about the laws and regulations that affect you and work to follow them at all times. Ignorance isn't an excuse. Undertake your verifiable CPD over your 5-year cycle and ensure it is continuous. So don't do it all at once. Don't leave it 3 years. We've still got to do 5 hours of infection control training over our 5-year period, and just make sure it's continuous. Watch each other to ensure your standards don't slip, but at the same time support each other to achieve the highest standards. You know, don't be offended if someone comes into the decon room and you haven't got your visor on and reminds you to put it on. They're doing it to help you look after yourself, and then onward to look after your family as well. So that brings us to the end of that PowerPoint. So well done. We've got through the first 2 hours of the day together, and then just any questions really.